Good morning, everyone, and welcome to this new session, Transforming Public Health. We will have three speakers, Miguel Luengo-Oroz from the United Nations Global Pulse in New York in the United States, Carmen Cabezas, Secretary for Public Health at the Government of Catalonia in Spain, and Edna Bosire, postdoctoral researcher at the Georgetown University in the United States and the College of Medicine in Malawi. So thanks very much. And I would like to welcome Miguel to start with the first presentation.
To share with you some ideas around artificial intelligence and how it can transform a public health. Because the reality is that we are living in a revolution. I mean, from what we buy, what we see, even how we make conferences is changing based on algorithms. So, I mean, we have an excellent opportunity to leverage those technologies for having an impact in public health. So UNGlobal Pulse is the Digital Innovation Artificial Intelligence Lab of the UN Secretary General. We are a small team, around 100 people, distributed in 4 innovation labs around the world, in New York, Kampala, Jakarta, and recently in Helsinki. And we do a couple of things. So on the one hand, we do innovations. We try to jumpstart new ideas, use these technologies to help the UN agencies fulfill their mandates. On the other hand, like walk the walk and talk the talk, we try to help in policy, in topics such as like data privacy, AI regulation, data sharing, and so on. And I mean, I've been working at Global Pulse for now a decade. I'm the chief data scientist and responsible for innovation. And over the last years, we have been trying to find out how non-traditional data sources can help us, I mean, really different agencies find new insights on human behavior, how we can help humanitarian action and sustainable development. But let me take one step back, okay? Because I mean, I wanted to talk here around, I mean, artificial intelligence and how this can help. I think it's important to understand that, I mean, nowadays AI is everywhere. It can machines can start to write things like humans. But I mean, they are not quite yet there. Still, in the last year, something has happened. Okay, it's like the more data you have, like the better results you get from the machine. Okay, and this is important. But also, it's important to know. I mean, and what is the meaning of this? So essentially, if I give the machine many pictures of cats, many pictures of dogs, the machine will learn to recognize a picture of a cat or a dog. However, the machine is not intelligent, doesn't know what is a cat or what is a dog, okay? So I think this is an important concept. When we use technology or AI in medicine, in clinical settings, we need to understand to which extent we can automate some of the decisions, or we can complement some of the insights that the doctors or physicians have, okay? And this is maybe like driving your car. I mean, it can help you park, but cannot drive alone, okay? So this is one of the challenges we will be facing in the next years, is how much we can leverage those technologies. And the problems that these technologies have is, on the one hand, is bias, okay? And because the technologies work on the data, so the more data they get, the better they work, but they encode the bias on the data they read, okay? And I mean, we have seen examples of this on help to medical image diagnosis, for instance, when you may have like data sets which are not balanced, that may work worse in different demographics, in women or men, depending on how the training data set was acquired. Another interesting point about AI is that also can help you create content that never exists before. I mean, we are seeing now TV advertisements. I mean, and this is something which is going to be important in the future, also for public health. I mean, there are extreme cases like the ones where you can inject a tumor that never exists in some medical images. But also this can help you generate synthetic data and generate things that can help you, okay? So this is the introduction on AI and what are like the main, how it works and what are the main potential caveats. But the reality is that I could now change my face by a cat, and this will continue to work. And the reality is that over the last years, we have seen an explosion of research on AI for medicine. It's that we're talking about dozens of thousands of research papers. And I mean, when the pandemic started, one of the first things that my team at the UN and together with WHO and other institutions did was like mapping, okay, what are the potential uses of AI for pandemics and AI for, in this case, the COVID pandemic. And we created a taxonomy, which essentially is a taxonomy based on physical scales, but it was an initial starting point, I mean, to map what are the options. So we said, okay, there are AI that works at molecular scale, AI that works at patient level, at clinical scale, but also there are topics that can be used or techniques that can be used at societal scale, okay? And here we have both epidemics and infodemics. So at molecular scale, I'm not going to go down here, but there are things like predicting protein structure, which are critical at that level, that now are problems that are solved much better with AI than with any other technique. Also, we have seen some searches for like a drug repurposing, or even on the way like drugs are developed nowadays. From a clinical perspective, we have like different options, okay, ranging from like medical imaging, really helping speed up diagnostics from X-rays with CT scans, to non-invasive measurements. Also, we have seen, I mean, how perhaps wearables are screening tools for the future. There are a number of clinical studies on those ways. We have also seen a number of works trying to predict patient outcome and even like planning like hospital capacity and regional allocation of patients. So, I mean, I think all these tasks are really very suitable for AI. Even one last, I mean, it's interesting how even like robotics can help cleaning, if you want, our places. On an epidemic perspective, also, it's interesting how many models have evolved and the number of data sources we have incorporated, like the way we have been measuring mobility and adherence to non-pharmaceutical interventions has been by looking to the number of mobile phones, which are, at least in Europe, which are connected to cell towers in one place and move to different places. Another interesting point or opportunity that I think we have not been able to leverage is digital contact tracing apps. I mean, I don't think this has been a success. I mean, probably because in the design phase, we have not I mean, the users are not just citizens, but also public health authorities, and the design might have to be like a little bit different. I think also it's interesting to talk about infodemics. I will go deeper a little bit later, but that's clear that this pandemic has been like the first infodemic. We have been like a huge production of scientific material, but more also we have seen a huge production of mis and disinformation traveling online in social networks, and that has like a huge impact. So, I mean, we have seen research on how to mine scientific literature, and also a new field starting, which is understanding how mis and disinformation related to in this case to the COVID pandemic evolves through the networks at a global scale. So coming back, I mean, this is the map, or like these are many ideas that you could use at different levels from different perspectives. Going one level down, we try to understand also, and this is like some lessons learned or things which were common to all these applications. I mean, the first one is, again, these are multidisciplinary applications. It's not just public health practitioners. They need to work with technologies. They need to understand each other. They need to trust each other and have a common language. That's not a given. Also, I mean, we saw a few weeks ago in the Lancet Commission talking about data solidarity. That's clear that the data space have been hyper fragmented. We need to do more there, like really do more on data sharing and finding the right data governance agreement. Sometimes the data that has public health value is sitting on the private sector. What is the right way to aggregate to share it. So you are protecting individual privacy, you are protecting competitive advantages, but still this has value for public health. And the reality is that very few implementations of AI have scale. Okay, one of the things also which is interesting is that maybe these applications can increase inequality or are just increasing the digital divide. So here I'm gonna deep down in a couple of works that we did in our team, trying to apply these technologies in places where are not so common. Okay, so 80 million people don't live in their houses, have been forced to flee, are refugees or internally displaced people, which is more than 1% of the population of the world. And when you look at the number of studies on epidemic modeling for these situations, there is less than 20 in output. Right? Okay, so really we looking at that, we made a coalition, and for last year we have been providing epidemic modeling support to the Cox's Bazar refugee camp, which is the biggest in the world with more than 700,000 people. And we have used a technique which is called a digital twin. So essentially we have built a simulator where every individual, where every location of the camp, where, I mean, like geography, shelters, learning centers, everything exists in a virtual world. And then we do simulations trying to see what will happen. We have particular operational measures like, for instance, open or close the learning centers, the school, like giving masks to everybody of particular quality, like changing the pathways regarding quarantine and so on. So really, this has been an example where we could use these techniques, which, I mean, has been only used in the UK as far as we know, but I'm putting this also in the working hand by hand with the staff in the camp to use there. So that's like one example. The second example I want to mention also a little bit on the limit is, as we said, so member states gave WHO the mandate also over the infodemic, okay, and this mis and disinformation traveling around the networks. We have seen this, I mean, in Europe, in social networks very, very clearly. It's not yet understood which are the mechanisms or diffusion, but still you need to know what's going on if you are the communications department of a public health agency to contract to gain trust in populations. And what happened, and what we also notice, is that, I mean, the reality of the digital space is that just 100 languages exist in the digital world, but as humans, worldwide, there are 7,000 languages. So there are many people which are left behind even for the digital space. And turns out that in many countries, particularly in Africa, radio is the main source of information. So in this case, what we have done is use artificial intelligence to understand infodemics coming from radio. So what you see here is the word COVID in many different languages, is, I mean, how it looks like for an artificial intelligence machine that do speech to text. Okay, so the idea is that we transcribe, we find those pieces of information that speak about vaccines, COVID, and so on, and trying to understand the trends and understand the messages that can be pulled, in this case, together with the African Infodemic Alliance Response Network, also that also works with fact-checking communities. So, I mean, we have followed a lot of rumors and around like local herbs that could cure COVID and things like that. I mean, from radio to social networks to the metaverse. I mean, my daughters will spend hours connected to the internet, I don't know, with gloves and glasses or whatever. But I think there is another perspective here on the digital space, is that maybe we are in the middle of a slow motion mental health pandemic. I mean, we need to understand what all these technologies are also doing to our brains, to the brains of our children, and also start to think that may perhaps also as a pandemic. Lastly, also maybe taking 2 steps back, I think I wanted to share with you like the latest report from the Secretary General is around our common agenda. And this report mentions a number of actions, of things that need to happen from the digital cooperation space, in the artificial intelligence space. I think for the future, thing we have seen in infodemics, we need accountability for discrimination and misleading content, but something which I think is particularly relevant for public health, for public health transformation, is the creation of global digital public goods. So digital public goods. I mean, I can see a weather map you can see a weather map. We can, and this is a public good. We all understand what is the risk of having a storm. We could have weather maps, digital public goods with the risk of having a new outbreak. We can have these maps with like information on like last cases and many other things. So I think that concept is particularly important. And the other message is that we really need multidisciplinary teams and research. This is our team. Half of the people have technical background. The other have like different specialties. And I think the future will come with, in this case, with the integration of public health practitioners, but also technologies. So thank you, and happy to take any question.
Thank you, Miguel. Any questions from the audience or from the other speakers that you have for Miguel? In the meantime, maybe I have a question for you. So thank you. This was all very interesting. And I'm wondering how to make the connection between all those analyses that you can do with the artificial intelligence and the actual policy. Do you have any examples, or can you think of an example that could be used for COVID, or that has been used for COVID? Because sometimes you do all these interesting things, but then it's very difficult to connect it or to translate it into actual policies that can help with a COVID situation. Mm-hmm.
Yeah, I mean, I guess that, I mean, for us, our building on what I showed before, the idea is that we build this in the camp, we build the digital twin, but then, I mean, there was a feedback loop between the practitioners, the public health experts, and the modelers. Okay, so actually we were producing reports based on questions that were asked by the field. Okay, so the policies essentially were influenced by all these simulations. So I guess that one of the key learning, and I mean, you need that shared language between public health experts, policymakers, and technologists. And that passes by having them all in the same room or the same virtual room. And that's something that you don't build overnight. I mean, that was our problem. I mean, our overall problem in the pandemic, because I mean, suddenly many people working on their field, many people doing that, but they were not used to work together, to share the same language. They didn't have the trust. Okay, and I think that is what we need. We really need to embed, in this case, I mean, technologies working with public health and policymakers, and vice versa, and influence policy. So essentially, the problem doesn't start in the technologies. The problem starts in the policymaker or the public health expert, and this is with what we work. Okay, then we develop the solutions. This is just tools. Okay, it's not, I mean, looking for the problem. I want the most complicated is to have the problem. Then we will build the tool. Right.
Yeah. Thank you. We have another question. So it says, mobile phones generate big data useful to track mobility, for instance. Mm-hmm. How can we proactively use mobile phones to prevent viral spread? Several apps have tried that, but have failed.
So, I mean, for me, my impression why all these apps have failed is again because of the same. The way they were designed just with one stakeholder in mind, typically has been, I mean, okay, citizens can, I mean, here you have multiple stakeholders. So you have like public health agency and you have citizens, and both need to be able to use the app. For that, as a citizen, I need to trust. For you as a public health practitioner, this has to be embedded in your workflows. It's always the same thing. It's always like two things that are approaching, but from the design perspective, they were not just put it into place. Technically, I mean, I think it's quite simple. Essentially, we need like the real-time data. I think we need to start to understand that we can refresh our risk maps, like with more frequency, that we can include extra signals that can help us. But then we have to find out like the two ways how we can tell the citizens. And again, it's question of having together all the map, all the people, all stakeholders that are going to work from day one, not at the end.
Mm-hmm. Okay, so another one regarding artificial intelligence and the management of infodemics. What would be the equivalent of a vaccine to prevent the spreading of fake news?
That's a good point. So the equivalent to a vaccine it's the information. Okay, it's the right information, it's the good information, and probably that's the equivalent of a medicament. And education is the equivalent to the vaccine. So really critical education. So we know, so we are citizens, we are taught to go for it. Then, that's like the long term. The short term is really you need a strategies to counteract the piece of misinformation. And then there is an extra level where if we manage to have accountability criteria for those that spread the misinformation from a legal perspective, it's almost regulation, then things will be much easier. And then you also can use, in this case, semi-automatic methods to go for those disinformations and try to suppress them. Some of the problems we have today is that the responsibility of this triage of the information many times is just on the shoulders of the private sector companies, which might not have regulations that tell them what they have to do or not to do. So I think we need more transparency on exactly how this filtering is happening, and that will help us develop more methodologies, more medicines, and vaccines. In any case, for me, vaccine is really teach critical thinking and from the beginning, I guess.
Okay, we're out of time, but maybe one final quick question. It says, with the infodemics and WHO, you gave us an example in the South. How is UN Pulse addressing some of the infodemics occurring now in Europe against the COVID-19 vaccination campaign?
Well, in this case, we are supporting member states in the global South. Here in Europe, we are not actively working. I guess that there are many initiatives from the EU and then individual member states, but we are not actively working here.
Great, thanks very much, Miguel. And I would like to introduce Carmen Cabezas now for her presentation. Thank you.
Thank you.
Thank you to the organization for the possibility to share with you some ideas about transforming public health in this era. Some years ago, we have this news in the newspapers, and Spain has one of the highest life expectancy in all the world, and especially related with factors that are outside of the health system, like the diet and the way of living of Spaniards. But that is not true for all the population, and one of the most important issues is the inequalities in health. For instance, here in Catalonia, in a distance of 18 kilometers, we have 8 years of difference in life expectancy. And also at the global level, there were some important challenges and opportunities for the health of the population. For instance, the aging of the population, or the climate change, or the globalization of the Sdgs, or the important urbanization of the population in our world. And for that reasons, one of the most important frameworks in public health is that of the social determinants of health, with the idea that more than 80% of the health determinants reside outside the health system. And we were working in this framework during many years, and also in the SDGs framework in the 2030 agenda, because health at this moment is not possible to think in health without thinking in sustainability, and also without thinking in well-being. And that was been our line of work for many years. This is the index rate, the index for SDGs here in Spain, and we have some problems with tobacco, with alcohol, with HIV infections, and so on, and also with violence. And that is the important problems to work in public health for the last decades. Using this framework, we have elaborated here in Catalonia a law for public health in 2009, and all the political parties agree with that law. And this is very important because it includes this perspective of health in all policies and in the importance of to work in inequalities and in the social determinants of health. And we have developed two versions of our interdepartamental and intersectoral plan in public health, trying to work with the other sectors of the society in order to improve our health. And our public health agency is related with this framework, and we have the main functions of public health, that is health protection, occupational health, epidemiological surveillance, and drug addictions and food security, and also, for instance, especially health promotion and disease prevention. But that is important, but we have been an evolution of the Health Protection Agency, and we have this territorial structure, but the most part of our people, more or less 1,000 people, are dedicated to health protection issues. And for instance, to do the surveillance of legionellosis and to work in the food safety issues and so on. The budget for public health in Catalonia is more or less 18 euros a person a year. Yes, only 1% of the budget of all the health department. And this is one of the actions. And in this moment, in this situation, it arrives the COVID. As you know, it started in December, more or less, December 2019 in Wuhan, and in a few weeks, it arrives to all the world. It becomes a pandemic. And that is the situation today, with more than 250 million people that have been past the COVID. And that is more than 5 million deaths that we have knowledge, but there are more than that. And it's important that the COVID changed all the situation, but also it's important to consider that the COVID is not a pandemic of an infectious disease, but is a syndemic that affects in an unequal way to the people in the poorest levels of our society, with this very specific socioecologic interface, and also that the syndemic is affecting to the NCDs, because the people that is affected by COVID, and also all the health system is dedicated to the COVID, and the NCDs, the cancer, the cardiovascular diseases is increasing at the same time for many reasons. Especially because the COVID is affecting more to the people with risk factors, and also with more deprivation, but also with the fact that if you are dedicating your resources to COVID, you are not dedicating the health system and the other resources to the other very important diseases. And also it's very important the effects in the economic of the society. For that reason, COVID-19 has caused the biggest decrease in life expectancy since World War II, and we can see here the difference, or the decrease in special countries. For instance, in Spain is one of the highest decrease in life expectancy related with COVID-19. And it's very important that the COVID has also effects in mental health and social health, and in the economic situation of all the society, establishing a circle of more inequalities and poor health. And it's very important to the idea that we need to cope with the COVID to put many layers of protection, and we have been working here in this is the pandemic chronology in Catalonia. We have been working here with a special strategy of test, tracing, isolation, and support, and that has included a transformation of all our public health system, and also we had to work with the people in the academia, in the university, and people that are working in artificial intelligence and so on, in order to predict the new waves, in order to cope with that, in order to act with that, and also with the people in the social issues, because we need to tackle the effects of the COVID in this social aspect, and also it's very important to work with that. We have to incorporate, to integrate in our public health system more or less 4,000 people, that is many people, and in order to cope with the needs of the pandemics. And that is very important because it stresses the need of improving the situation of public health in our system. And we have also to administer more than 11 million doses, working together with the health system, and in a very changing way, because the new vaccines are arriving during the year, and we have to adapt to the new situation, and we have to put in practice many things in order to administer to all these vaccines in the different age groups. For that reason, that is important this situation to adapt to the changing situation. This is one of the most important issues in transforming public health. We need a public health that is capable to adapt to new situations that are changing every moment. And also here, this is a paper of the Lancet of the last week, trying to compare the regulation in the international health regulation with the actual situation with the pandemic, and identifying new ways to act in the new pandemics, and that is very important. And also, there is important that in 2021, it's important to remember that it's not only the pandemic and the COVID, the important things, that there are many other things that as inequalities, as antimicrobial resistance, and so on. And in this aspect, it's very important to integrate the concept of One Health. And I think one of the most important lessons of the pandemic is to integrate and not put in only in the middle of our action the human health, but also the animal health and the environment health, and working in this concept of the planetary health, and working together with all the sectors of the society in order to work to improve this One Health. And that is very important, and the concept of determinants of health is changing. And also in these three main objectives at the global level for the WHO, it's important that two of the main ideas of work are related with public health. For instance, this one of health emergencies, and also the second one of health and well-being. And in health emergencies, it's very important to learn lessons from the COVID-19 crisis in order to prepare for the new ones. And also in the topic of health and well-being, it's very important these things of working in inequalities, working in the intersectorial action, and also in developing strategic intelligence on the different levels. And also we here in Catalonia, we are working in a public health agency for this 21st century, and we need to incorporate and to integrate in our agency new professional profiles, and we are working together with other profiles, and we need to integrate that. And also we need to boost our health in all policies approach to integrate this concept of One Health. And also we need to create this epidemiological intelligence center for Catalonia. And we are working in all these three fields. Yes, and also bringing this salutogenic approach in order to identify the resources and assets for health in our community. And at last, the key remarks, the final ideas is this crisis, the crisis that is caused by the coronavirus has highlighted the importance of public health. We have this priority to cope with new emergencies and new pandemics, but also with the inequalities in health, with the climatic emergency, with aging, with mental health, with the role of people and communities in their health, and also with the prevention of the NCDs. And also we need powerful and well-financed public health agencies to cope with all these topics, and also with professionals profiles of new profiles adapted to the new needs. And that is.
Thank you very much, Carmen. We cannot see you now. I think there's a technical issue with the video, but thanks for the presentation. We have a question from the audience. They are asking, do we have any reliable prediction of the impact of COVID-19 pandemic on other diseases, particularly on the long term?
We know that some diseases like the cancer and like chronic diseases has been not very well addressed during the period of the COVID-19 pandemics. And we know that also some strategies that we use to cope with to confront or to cope with the pandemic has related or has been influencing the sedentarism and the food intake of the people and so on, and also the mental health. And we know that they are this influence in these NCDs and in all the health of the population. I think the most important figure at this moment is that during the 2020, the life expectancy is more or less 1.5, 1.7 lower in Spain, for instance, a little bit lower for women.
Do we have time for another question? I'm assuming yes. So we have another question. Congratulations for the excellent vaccination campaign in Catalonia, an example of the adaptability of the health system. Which is the limit of this adaptability with the current resources?
It's a very good question. And I think that we have been using all of our health system in order to vaccinate the population, more than 11 million doses. At the same time that we have been administering 3 million doses for all the other vaccinations in our vaccination program, because the children and so on, we have been vaccinating them. But now we have to administer the booster doses. We have to administer to the flu vaccine. And also during this time, since the end of December of the last year, we have to cope with 3 waves of the disease. And that is it's a very stressful situation for all the health system. I don't know. We are trying to pay for complementary. Well, we pay, in fact, for complementary hours for the people that is working normally at the health system, but work at the vaccination sites in complementary hours. But there have been doing that for 8 months, and now they are tired. I think it's a stressful situation, and we have to find a way to make the best use of the resources, because there are not other resources. We made a call for all the people of the health professionals, not only in the public system, but in all the system, in order to incorporate to the answer to the pandemics. But there are not all their health professionals without job, and it's difficult to cope with all that. I have many words of thanks for all the health professionals that are being involved in the vaccination campaign, and also in all the response to the pandemic, and in public health and in academia, in all places.
Thank you very much, Carmen. I think we don't have more time for questions, even though we have a few more. And thank you. I would like to now introduce Edna Bosire for the final presentation. Thank you and welcome, Edna.
Thank you so much. Can you see my screen, please?
Now we can, yes, but we are not seeing it in full presentation mode. Yeah, now it's great. Thank you.
Yeah, thank you so much. And I'll be talking about syndemics, understanding COVID-19 through the lens of syndemics, and Carmen has briefly touched on syndemics.
Edna, sorry, we're seeing presentation mode, so I think that's what the presenter should see, not what we should see.
Oh, okay. So, can you see it now?
Yes, that's better. Yes, thank you.
Is it clear? Okay.
Yeah, good, thank you.
Thank you. Yeah, so just briefly, what are syndemics for people who might have not heard about this word? So syndemics is a combination of two, it's an acronym actually of two words, that is synergies and epidemics. So the architect of syndemics is a medical critical anthropologist called Meryl Singer. And in the early 1990s, while she was trying to understand HIV/AIDS amongst women in the US, she found that it was difficult for her to understand HIV/AIDS without really looking at other social and economic and ecological issues. So she coined this word syndemics. So syndemics are related to epidemics, and they are never related to pandemics because they are locally driven. So we all understand epidemics, pandemics, endemics. But when we talk about syndemics, as I mentioned, they are related to epidemics. It's a dynamic relationship involving two or more epidemics and the social factors that drive the interaction of diseases. So what makes a syndemic? So there are three kind of principles that really guide the syndemic. For a syndemic to take place, number one, two or more diseases must cluster in a population. Then these two or more diseases, they have to interact. And this interaction can be biological, psychological, or social. And when these diseases interact, then the social and structural factors at the community level then drive this interaction and can lead to adverse effects. This is what this model is trying to show, to simplify the syndemic interaction of one or two diseases, which then will lead to enhanced disease transmission, progression, and negative health outcomes. So Meryl Singer came up with the SAVA syndemics, as I mentioned, when she was trying to understand HIV/AIDS amongst the women in the US. And this SAVA is basically means substance abuse, AIDS, violence, and AIDS. So you can see this triad. It shows that there's an interrelationship between all these factors. So we have the social violence, or maybe some early life experiences, which might be negative, and familiar and social networks. So all these factors come together to lead or to develop a syndemic. So for instance, when you look at patients, what she found is that these patients with HIV/AIDS is not really the disease that was making them sicker, but the syndemics, the interaction of these diseases or interweaving of the disease itself with poverty, with instabilities, drug abuse, and other factors at the community level. But closely related to the SAVA syndemic, Emily Mendenhall has written about syndemic suffering. She has studied or conducted a lot of studies amongst Mexican women trying to understand type 2 diabetes, and she came up with VIDA syndemics. So the VIDA syndemics tries to show a relationship between diabetes with other underlying social factors. For example, VIDA stands for violence, immigration, depression, diabetes, and abuse. So you cannot understand diabetes, for example, without looking at other underlying factors. And when we talk about SAVA and VIDA syndemics, they do not cut across all communities. So it's important to understand a specific community where you are doing your research or where research is taking place, and the contextual factors that are pertinent or really key in that community. So the VIDA syndemics is what she found amongst the Mexican women. So we've done a lot of studies in Africa, some studies in Kenya, we've done studies in South Africa, and what Emily did in India, and also in the US. And we've looked at patients with multiple chronic conditions such as type 2 diabetes, HIV, cancers, that is breast cancer and prostate cancer. And in all our experiences for over a decade, we've never found a patient talking about a singular disease without really talking about other factors that are precipitating or that leads to these diseases in the first place, or even trying to demonstrate how the disease interact with other social issues at the community level. And so it's not, as I said, it's not the disease really that make people weak or sicker, but because of this interaction, clustering, and how the social, economic, and structural issues drive these diseases is what makes it difficult for the patients to manage the diseases that they have. So syndemic care requires that we recognize how social problems cluster with and how they cluster and interact with other medical conditions. So moving forward, is COVID-19 syndemic? This is something like during COVID-19, we've seen publications really coming up, others saying COVID is syndemic, others arguing in the opposite way. So Richard Horton recently called COVID-19 a syndemic, and Emily Mendenhall countered such arguments to say COVID-19 is not necessarily a syndemic because the context matters. So what is happening in one country might not be the same thing that is happening in another country. So just brief studies in Africa, a few examples. During the first wave of COVID-19, we saw statements that could be really racial, or I could see that they were really racial or stigmatizing comments about Africa, and some people wondering why is it that people are not dying in Africa? And you'll wonder, so were people supposed really to be dying in Africa? But it's because of the trend and how disease patterns have been manifesting over years, over decades. For example, HIV and other NCDs now, they of course have devastating effects in Africa. And so most people would assume with COVID-19, the same should also be happening. So we've done studies in Kenya on COVID-19, and we actually found variations in different towns. One town where we conducted a study is called Eldoret Town in Kenya. And this is a rural town. And what we found is that there was, of course, in Kenya, generally, there was a good response and preparedness to, to combat COVID spread at community level. The first case of COVID-19 was reported in Kenya on the 12th of March, 2020. But by February, the government had put mechanisms in place to limit spread at the community level. That picture there on the right bottom, there is a picture where you can see a small car. This is a police van moving around town and telling people, oh, you have to stay at home if you really don't have to be in town. You have to try and protect yourself. So the government, the county governments really took a response and tried to sensitize people using television, radio, using local languages. And this is something that was even reported in the local media. So you could see differences. I'm sure there are other towns in Kenya where we saw police brutality, trying to force people to stay at home. Of course, it had its own implications, but the response rate in Africa, I could say, was very good to combat the spread of COVID in the first wave, and this really minimized outbreak at the community level. If you look at another case is from Rwanda. Rwanda is a rural town, and we also saw very good response rate. If you look at the graph, Rwanda really, we did not have this COVID being a syndemic because the measures were put in place really quite early, and this helps to reduce the spread or the outbreak at the community level. The same was also realized in New Zealand with proper leadership and mechanism being put in place quite early. It also reduced the spread or for COVID to interact with other issues at the community level. And closely related to New Zealand is what we observed from Germany. This is contrary to what we saw in the United States, for example, where we saw a lot of COVID cases, infections, a lot of deaths, and these are partly because of the issues to do, a lot of inequalities that existed, but because of the leadership at the time, I could argue that really what the leadership, the kind of message that the leadership gave to the population determined how people perceived COVID and the risk, whether they perceived themselves to be at risk or not, and whether they really decided to take preventive measures or not. So leadership is very important, and the message that leaders provide to their communities also matters a lot. We also saw COVID-19 really interacting with other diseases, including diabetes and hypertension. This is not just a specific example from the US. We know COVID has really been, it has been so severe to patients with other underlying conditions. So why Syndemics matters? Syndemics is important because it helps us change and the way we think about diseases. We recognize that rarely do diseases exist in isolation. We are talking about COVID-19, but this COVID-19 is not happening in a vacuum. There are other issues already in place, especially in Africa, where we have a lot of inequalities, we have a lot of poverty, we have other diseases. Still, Africa is grappling with tuberculosis, HIV, and now there is a really massive increase in non-communicable diseases, including type 2 diabetes. So Syndemics helps us to understand how the diseases cluster, how the diseases interact, how these socioeconomic factors drive diseases, and therefore measures can be put in place at the right time. So moving forward, it's important to act decisively, act together, and act now. We don't need to wait for things to really escalate. So there's need to have to start thinking in a transdisciplinary manner, bringing different disciplines together. For example, social scientists are people who have been thought to be not really very important when it comes to things like pandemics. But we've been conducting, I'm an anthropologist, and we do a lot of hospital and community ethnography. So this ethnography really helps us to uncover some of the things that the biomedical frameworks might miss out. So it's important to bring all these disciplines together to combat diseases such as COVID-19. And also it's good to cultivate a comprehensive view of how syndemics emerge, converge, interact, and change throughout time. It's also important to identify methods that try to test how syndemics cluster in populations level. But lastly, we saw Africans really responded. In most African countries, there was a good response in the first wave. And I feel like other countries in the developed or in the global north can learn from Africa. I don't know how easy this is, but we have to acknowledge that Africa have had enough experience dealing with other epidemics such as Ebola and other diseases. So when COVID hit Africa, some of these issues were still fresh in their mind, like in Democratic Republic of Congo and Sierra Leone, where Ebola has really been a case issue for a long time. So managing COVID-19, therefore, people are able to prepare or to act fast compared to countries where they've not really experienced some of these diseases. Then we have some of the other factors. As I mentioned, COVID doesn't exist in isolation. We already have inequalities at the community level. So there's need to look at the upstream and downstream solutions, such as food policy, housing policy, healthcare policy, ensure that people have universal health coverage. We saw people without health cover really suffering during the COVID-19, and immigrants, people without proper documentation, really suffering without being able to access healthcare. Downstream solutions are ensuring, for example, we have community gardens or practitioners or researchers are able to work with lay leadership to ensure that, you know, they support the communities with grants and small support to allow them to really cope when we have such situations such as COVID-19. At clinical level, it's really important to look at integrated and patient-centered care models. These are very important because I don't think there's any country that is now talking about COVID-19 without other underlying medical and social issues. So clinical, there is need to strengthen the healthcare system so that patients are managed alongside other diseases that may be clustered together easily or other social issues that patients experience. At community level, there's need to also come up with community mental health programs. As my former colleagues mentioned, maybe we are waiting for a mental health pandemic in a slow motion. So these are some of the things that need to be put in place earlier enough, peer group counseling at the community level, but also addressing rumors and confusing messages of COVID-19, including vaccines. I've come to the end of my presentation and I will welcome questions. Thank you.
Thank you very much, Edna, for this very nice presentation. We have a question from the audience. It says, thank you for clear points and examples and learning from Africa. Based on the syndemic approach, is there an existing international framework picked up or developed by international organizations, for example, WHO or UNAIDS?
So we have the syndemic model and that I talked about, but I don't think I've seen a larger scale or trying to incorporate this syndemic framework. That's why we are promoting and saying there's need to look at syndemics and try to, you know, bring it up to other like WHO's recommended health frameworks or things that frameworks that are aimed to address these diseases. I haven't seen, and if it's there, I will be able to maybe check, but I haven't seen any.
Thank you. I also like this, what you said about developed countries having to learn from African countries. Do you have any specific examples of what exactly they can learn from? What did the DRC and Sierra Leone do well for Ebola that could be extrapolated or used for other pandemics and COVID-19, for example?
Mm-hmm. Like during Ebola, we saw, for example, people using outside spaces, really important to help people, you know, get some air and sunlight. And like from those countries, you see people talking about this kind of approach helping. So this is something that maybe someone might think it's not really useful, but trying to understand how can you use whatever resources you have to try and respond to a pandemic such as COVID-19. Another thing is to work closely with local leaders, because in Africa, local leaders, they only want to see people die because they need these people to bring them in, to elect them into positions. So sometimes, as much as you can see a lot of corruption cases in Africa and other really challenges, but when it comes to pandemics, people tense, and there's that closer working with populations, and there's a kind of collaboration. However, I mentioned we still saw kind of police brutality in some countries, including South Africa, and also, you know, trying to force people to comply when their livelihoods cannot allow them to comply or stay at home.
Yes, of course, the socioeconomic situation determines what you can do in those cases. Okay, we have another question. What are the main differences in the response to the pandemic between African countries and India? Were there also frequent epidemics which lead to so different outcomes?
Yeah, so what I can say for me, what I observed, I think, is leadership. As I mentioned, how leaders prioritize issues is something that differs. So the way I saw most other African countries, the leadership, the way they responded to COVID-19 is not the same pattern that was observed in India, for example. And this also matters because then it depends on how people think about the pandemic, the seriousness, and whether or not they think that they are at risk of getting infections. So leadership is very important.
Mm-hmm. Thank you. Any other questions from the audience or from the other speakers? It's already 2 minutes past noon, and we were supposed to finish at noon. So thank you very much to all the speakers, and thanks for all the questions as well. I would just like to remind you that there's a lunch break now, and we'll be back in 2 hours. And in 2 hours, the last sessions will include the pitches session and the meetings between the projects, the startups, and the investors. So have a good lunch, and see you later. And thanks again, everyone.